Hi, everyone. Welcome back to the Doc Talk podcast. I'm Dr. Sheila Wijayasinghe.
And I'm Dr. Shazma Mithani.
So tell me about your week, Shaz. I know you have a busy week coming up, I think.
I do. Yeah. I thankfully had a few days of rest over the weekend where I didn't have shifts. So I got to recharge, take some time, spend time with my family to prepare for a pretty big stretch coming up here. So I've been just anticipating these shifts coming up. And I'm thankful that it's not just a long slog, that I did have some rest before and I have a little bit of rest after too. How about you? How's your week been?
Good. I mean, I don't know how you do your overnights. I can't do that. I was away this weekend, actually. I went to Arizona for a sexual medicine conference, which was really wonderful. I got a little extra sleep because I wasn't with my kids. So It was a nice little break and a little sunshine. And I'm excited to share with them, maybe in a future episode, if someone has questions around sexual medicine. Always a reminder, if you have questions for us, please do send them in. We want to hear from you because we are basically guiding the decisions on what we produce based on what you want to hear.
Yeah, and please, you can DM us on our Instagram account at the Doc Talk Pod, which is exactly how we got this question for today's topic. So today's topic is inspired by a listener question on the important topic of colorectal cancer. So colon cancer is the third most commonly diagnosed cancer in Canada and the second leading cause of cancer death. So understanding screening and prevention is crucial. So let's take a listen to this listener's question.
Hey, Dr. Shaz and Dr. Sheila. This is Justin calling, and I had a question for you. I'm wondering about colon cancer, specifically in people around my age. I'm 44 now, and as far as I know, I've never been screened. I hear about more and more people getting diagnosed with it younger, and I'm wondering, what are the guidelines? What are the different ages that you're supposed to get screened, and what should I be thinking about with respect to colon cancer?
This is such an important topic. Yeah, absolutely. It's such an important topic that we're definitely hearing more and more about in the media, right? And so with celebrities like Chadwick Boseman, who was diagnosed in his early 40s, and then more recently, James Van Der Beek at the age of 47, they've certainly brought this type of cancer into the spotlight. And so for our listeners today, we are going to answer Justin's questions. We're going to cover some stats. We'll talk about the different screening tests available. We'll address kind of throughout the podcast different questions that Sheila and I both often hear from our patients. And so, in the ER for me, I definitely see a broad range of presentations of colon cancer. So anywhere from a new diagnosis with mild or new symptoms to end stage colon cancer. I mean, we certainly are diagnosing a lot more cancers all around in the emergency department, which is why that early detection and prevention is so important. So let's dive right in. So why don't you tell us more about what exactly colon cancer is, Sheila?
Yeah. So, we use different terms for colon cancer. Some people may hear colorectal cancer, bowel cancer. We're going to be using the term colon cancer when we're discussing it today. Now, specifically when we talk about colon cancer in this context, we're talking about cancer of the lower intestine or the large intestine. And that's the part of the bowel. So when we eat food, it goes through our esophagus into our small intestine, and then your nutrients get absorbed, and then it travels down into the large intestine where water gets absorbed. And that's where we start to see, that's where we're focusing on today, because that's where the cells, if they overgrow, it can create something called polyps. And polyps over time, they're considered a precancerous lesion. They can actually over time develop into cancer. And that really highlights why it's so important for us to discuss this, because we know that if we can detect colon cancer early, there's a very high cure rate. And in comparison to other cancers, as you mentioned it up front, that, it's a very common cancer, we are seeing colon cancer becoming more picked up in younger individuals in Canada, specifically under the age of 50. So in women, colon cancer currently falls behind in frequency to breast cancer and lung cancer. In men in Canada, it falls behind lung cancer and prostate cancer. And so altogether, it's quite a common cancer, but a leading cause of cancer-related death. And it's estimated that by 2030, colon cancer is going to be the leading cause of cancer-related death in individuals under the age of 50. Wow. And that's a really important stat because that's something new. I've seen it more in my own practice where people are being diagnosed early. We're screening a lot in our practices, but there isn't a great uptake of screening, unfortunately.
And that's exactly why this is such an important topic. I mean, you mentioned a polyp and it's a precancerous lesion. So this is an ideal cancer to screen for because there is actually something that you can pick up before it turns to cancer. Totally. whether it's by, the FIT test, which we'll talk about, or a colonoscopy, which we'll talk about as well. But I think it's important for our listeners to understand the stats in a bit more detail. And so in Canada in particular, it's estimated that almost 25,000 Canadians this year alone are going to be diagnosed with colon cancer. And what's even more concerning about that is the almost 10,000 people or 10,000 of those cases are going to result in death, which is scary. That feels like a scary number to me. The lifetime risk of developing colon cancer in men is about 1 in 14, and in women is 1 in 18. And in particular, this is where early detection becomes so important, because when detected early, like in that precancerous stage, the 5-year survival rate, it can go upwards of 90%, which is amazing. But only about half of eligible Canadians are actually up to date with their screening. So Sheila, can you tell us what kind of screening options are available for people in your office, like with their primary care providers?
Yeah, for sure. And I can't understate how people live well after an early detection of colon cancer. They get treated, they have surgery, or they have chemo, or whatever it is that they need, and it's actually treated very quickly and high cure rates. And it's incredible to see my patients after their treatment, they live normally. And that's very different than other types of cancer. And so that's why, again, we wanted to focus on this, because there's something that we can do. Mm-hmm. And specifically what we do in family practice is screening. And that's a big part of family medicine, is preventative care. And screening specifically is the type of test that we do on asymptomatic individuals. So people who do not have symptoms to begin with. And a lot of people are like, well, why would I test for something if I don't have symptoms? That is because, again, it goes back to if colon cancer can develop very quietly without warning signs. So proactively screening in our patients can really help us pick up those things before they develop symptoms themselves, and helps us with that, achieving that level of cure. And so specifically, we're going to talk about this a little bit in further detail, but what we do in our regular checkups, and specifically in individuals over the age of 50, is that we talk about screening tests, specifically the FIT test, which is a fecal occult test that we get sent to the home, or a colonoscopy, depending on your risk level.
And that's such an important topic, because in the emergency department, I often see patients once they're already experiencing symptoms. So they might have rectal bleeding, they might have abdominal pain, they may have a change in their bowel habits. So by the time somebody already has these symptoms, the cancer may have already progressed, which is why regular screening by a patient's primary care provider can catch those cancers before the symptoms even appear.
Totally. And this is why I discuss this with my patients regularly, and I encourage all of our listeners to do this as well. Create a plan for what your screening patterns are going to be. It's about making it part of your routine care. So just like we do routine blood work, we do mammograms or blood pressure checks, we should also be doing colon cancer screening at the same time. Again, because we can catch these changes early, and we can treat it early.
And that's exactly it. And to add to that, in the Emerge, we sometimes see patients with quite advanced symptoms. We're diagnosing lots more cancers in general in the ER. And it's unfortunate because many people actually, when I talk to them, they've avoided screening due to fear or discomfort or just general health anxiety. But in reality, waiting until those symptoms develop, actually, you're a step back already at that point, because it actually ends up making your course much riskier. Whereas if the screening had happened, we could have caught it earlier, and there could have been a much better prognosis and outcome.
Totally. Screening is an act of self-care. It's preventative health. It's basically like a check engine light before it actually goes off, just to address the things early before they get serious, right?
Exactly. So let's talk about the actual screening tests. So there are two main tests for screening. One in Canada. One is the FIT test, and the other is the colonoscopy. The FIT test is definitely more of a primary care test. So Sheila, can you tell us more about what exactly it is and what it entails?
Totally. So the FIT test is called the fecal immunochemical test. It's a non-invasive test that basically checks for hidden blood in your stool, and which is an early sign of cancer, but we don't often see it with our own eye. And so there can be hidden blood in your stool. And that's why it's really important to do this test. And it's recommended in Canada right now. The general screening guidelines are that we start screening for colon cancer at the age of 50 for people who are at average risk. So those aren't people who have a family history or have symptoms. There are people who are at average risk and don't have any symptoms. Now, this kit is really easy because it's something that gets mailed to your home. I just send a fax in from my office, and I get a reminder if patients are due, or patients will remind me that they're due, which is, I love that when patients call me and tell me, hey, Dr. Sheila, can you send me my kit? I fax it off. They get mailed the kit in the mail, and then they do one day when they're going poop, which we poop every day, hopefully, or whenever you poop, and you take a little dab of that stool, and then you basically send it into the kit. There's instructions that come with the kit, and you send it in, easy peasy. Tell me a little bit, but that's one test that we have. Some people choose to do the other test, which is colonoscopy, Shaz.
So colonoscopy is also a screening test. So what it does, it's like a flexible tube that has a camera at the end. So you actually get to directly, or the provider that's performing the scope directly visualizes on a screen with that camera what the entire large intestine or colon looks like. And so the lay term that we use is a scope for that. And then if there is anything identified, it can be removed. For average risk patients, it's also generally recommended that 50 is kind of that starting age. And so for colonoscopy, from a screening standpoint, it's recommended that starting at age 50, people can get screening colonoscopies if they're at average risk about every 10 years. If you have high risk, or if you're a high risk individual, so that includes a family history of colorectal cancer or polyps in a first degree relative under the age of 60, or a personal history of cancer or polyps, then that screening should actually start earlier. And that actually is, if it's okay if I tell a little story about myself,
please.
So that's actually relevant to me. I have a first degree relative who was diagnosed with a precancerous polyp before the age of 60. And so based on my province, I'm in Alberta, so based on my province's kind of screening program, because I have a first degree relative, the actual best screening test for me is a colonoscopy rather than a FIT test, because I'm a higher risk individual. In a normal risk individual that doesn't have a family history, a FIT test or a colonoscopy is appropriate. But in someone who is higher risk, in general, the first screening test should be a colonoscopy. And so that should actually start based on my province's guideline at the age of 40. I turned 40 this year.
Congratulations.
And so,
it's a good decade.
Thank you. Yeah. So, I mean, I had my screening mammogram at the beginning of this year, pretty much the month after I turned 40. And then now, after having a conversation with my family doctor and kind of going into my family risk factors, we kind of had an informed discussion, and I decided that I wanted to move forward with getting this screening colonoscopy. So I'm actually scheduled for it next month. I'm a bit nervous about it, to be honest, but thankfully, I have a family member that's been doing this screening for 2 decades now. And I have lots of friends who have had to do colonoscopies as well. And so they've been able to reassure me and kind of let me know that it's really not that bad. And so, I mean, I'll certainly let you guys know how it goes and see. But I think, kind of like you said, Sheila, I like how you phrased it, that screening is a form of self-care. And I certainly feel that way as well.
Yeah, it's, my patients always feel really good when they do these tests. I know it's a little bit nerve-wracking to talk about it and think about cancer. I think cancer is a hard thing to discuss, but they feel like, okay, I've done it now. I'm up to date, and they feel a sense of accomplishment with that. And I think that's really important to emphasize. If you take one thing from our episode today, is an important opportunity to think about what you're due for and get those tests done.
And I always kind of think of it as, with my mammogram earlier this year, and then with my colonoscopy coming up, I have anxiety about what if something is positive?
Yeah.
But then I try to logic through that a little bit of it's better that I find it now than just have symptoms, right? And so because at this point, it's going to be much more easy to manage if it's picked up in a screening test.
Totally. You're going to have to report back on how the prep went, because I know that is one thing that people have a struggle with. So we can definitely talk about that too. So you brought up another really important point, Shaz, around how often we should be screening individuals. For average risk individuals, it's either every 2 years with the FIT test, that mail kit test that we get sent to your home. It's every 10 years for a colonoscopy. Now, for some folks, if you've had a colonoscopy and they do find a polyp, which is the advantage of the colonoscopy, the FIT test, we can't see the polyps, so the colonoscopy it's a direct visualization. If you have a polyp and they remove it, they may suggest that you repeat that colonoscopy, not in 10 years, but in 5 years. And they evaluate that. So when you're working with the individual who's doing your scope, they'll go through what your risk factors are and come up with a plan. Again, like we talked about, creating that health plan for yourself. You know that, okay, I'm due again in 3 years. I'm due in 5 years. And you put it into your calendar and you know that that's when you're due. Again, if you're first degree relative, though, if you have a first degree relative, it's important to note that's when you qualify for a scope, generally, not the FIT test. And we suggest that you start screening with a colonoscopy, not at 50 like everybody else. You start screening 10 years prior to that individual's cancer diagnosis. So if your family member was diagnosed, or a polyp diagnosis, so if they were diagnosed at 55, you would start screening at 45 instead.
Exactly. And so, for my family member, that colonoscopy, as you mentioned, one of the benefits of it is that it can be curative in that moment, right? And so that high grade polyp was removed. They then had more frequent colonoscopies. They've now been able to be stretched out because the subsequent colonoscopies have been okay. And it was a life-saving intervention, right? Because it was a precancerous lesion that if that colonoscopy wasn't done, and from what I remember, I think it was actually picked up on it was picked up on an abnormal fit test. And then the colonoscopy was done. That lesion was seen. It was removed and it had not spread. Because when you do the pathology, you can see kind of how far into the bowel wall it's gone. It had not spread. There was ongoing routine colonoscopies done, and it was essentially a life-saving intervention. And so I think that's an important thing, again, to just drive home. Sheila, some people may wonder about what the risks of these tests are. And so can you tell us a bit more about what the risks are related to a fit test or a colonoscopy?
Totally. Yeah, I think that's a really important question. Anytime we do any sort of test, we have to go through the risks and the benefits of any of these tests so people can make an informed choice as to what they want to do. So for the FIT test, there's virtually no risk because you're basically collecting your poop. We poop every day, every other day, and it's not invasive. And you send it in, that's all it is. It can be icky. Like that's mainly the side effect that I tell my patients. I'm like, this might feel a little bit icky. However, the benefit of this is that we may pick something up that we can manage really early. And we have to forego that icky feeling just for that day and go forward. And that's kind of how we talk through it. Colonoscopy itself does have a small risk. It is a procedure. You have to prep for it. You have to take off time from work often for that. Well, yes, every time. And because it's a scope that's going into the rectum and into the colon, there's a risk of bleeding or something called perforation where they actually can puncture through the bowel wall. Especially this is a higher risk if they're taking a polyp off or they're doing a biopsy. This risk is about 1 in 1,000. It's considered quite safe, though, generally, even though there's this risk. It's just important to know that because there is a risk with this. It's not completely risk-free. There's also the risk potentially of sedation because you're not awake necessarily during the procedure. Some people do choose to do this awake and they're talking through the procedure. Some people get sedated, so they're sleeping through the procedure. So there's a risk of sedation risk that also can happen. Yeah. I think the benefit outweighs the risk, though, for most people.
And that's exactly what I was going to say. It's pretty much what medicine is, right? It's always weighing of the risks and the benefits when it comes to screening tests, when it comes to other interventions. It's, what are the risks? And we need to make sure that we all understand what those risks are and what are the potential benefits. And we need to understand what all those potential benefits are. And then you decide which one outweighs which. And if the risk outweighs the benefit, we typically don't proceed with it, right? But if the benefit outweighs the risk, that's it. We kind of accept those risks in an informed way and move forward on it. So I think that's a really important discussion to bring up because it goes beyond just this discussion on colon cancer screening.
Yeah, I have patients who aren't doing colonoscopies anymore once they hit a certain age because their risks for bleeding and other complications is higher. And so the decision's made at a certain age that they stop doing those screening tests because, again, they're at an age where maybe even detecting colon cancer early wouldn't make a big difference to the longevity of their lives. And that's a difficult conversation, but there is an important one because we, again, don't want to put you at risk if it's not necessary and it's not going to make a change in your outcome.
That's exactly it. So I want to talk more about symptoms because I think this is important for our listeners to know about, and I'm sure they want to know about as well. What sort of signs might prompt a patient to get further investigation, to come and see their family doctor or potentially come and see me as well, depending on the symptom?
Totally. And again, this comes down to, I wish patients came to me earlier when they have symptoms related to potential colon cancer. And I think there's, again, a little bit of a shame talking about poop or changes in bowel function or blood in the stool. And we have to stop that shame because that is what stops people from coming in and getting that help early. And so I encourage you again, Shaz, you and I talk about this a lot. Let's talk about poop. Let's talk about the difficult topics. That's why we're here. Let's talk about this. When you have this episode, share it with your loved ones to be let's talk about these things. We all poop. We all have these changes that happen in our body, but we can support each other to have these conversations, especially when there's a change. And specifically when we talk about colorectal cancer, the changes that can happen can be really subtle. So they can be just a change in your bowel pattern. So maybe you're going more frequently or the size of your stool has changed and it's consistently in that different shape or size consistently, not just a one-off thing. Our poop changes all the time depending on what we eat. But if it's a consistent change over time, that's important to get checked out to make sure that there's not something interfering with the colon, the stool forming in the colon. Blood certainly is a alarm feature that we always look out for. So blood in the stool, bright red blood can be from hemorrhoids, but it can also be from colon cancer. So we want that to be checked out. There's a type of blood in the stool called melena, which is dark tarry stool, which is bleeding from higher up in your GI tract. That's also a reason to get checked out. And one thing that we don't talk about enough is when you have anemia. So people who have anemia or iron deficient anemia, that can be a sign that you are slowly leaking iron or blood. There's blood loss in your colon that you may not be seeing with your eye, but it can be happening. So if I do, especially on a male, if I'm doing a test, because women menstruate, and so as a result, if they're menstruating and they have iron deficiency, I kind of can see that might be related to that. But in men, under the age of 50 especially, if they have iron deficient anemia, we always actually we consider doing a scope in those situations. Men of any age, really. Women of over 50 also, we consider them in high risk because menstruation generally stops around that time. So I do think those things, mainly just to summarize, so change in bowel habits, unexplained weight loss can also be a sign of colon cancer, blood in the stool, or anemia that we discover on our testing. Those are all symptoms that we can have. How about you, Chad? I think you're seeing people in the emerge with more advanced symptoms.
Yeah. And so, certainly in the emerge, I see patients with all of the symptoms that you've mentioned, but in particular, those symptoms can be more severe. And so in particular, I may have someone come in with months of unexplained weight loss that they are concerned about, or much more severe episodes of either blood in the stool or severe abdominal pain. And so when they come to see me in the ER, we typically start doing some initial tests like blood work, so looking for things like anemia, right? And then doing imaging, like things like an X-ray or a CT scan. And then depending on what we find, we would refer them to specialists like a gastroenterologist for a scope. Or if we clearly see a cancer on the imaging, then that's where we would think about actually just referring them to a general surgeon, because that's when surgical options are needed to be discussed at that point.
Right.
So before we wrap up, I do want to talk about prevention, because again, this is such an important thing for our listeners. So tell us about what steps people can do to reduce the risk of developing colon cancer.
Totally. So, we know that about 25% of colon cancer is related to family history. So that is a risk factor that is non-modifiable, or that we can't change it. But 75% of colon cancer, we don't know why that happens for people. And we actually think that there are things that we can do to reduce your risk. And specifically, there's things around dietary changes that are really important. Specifically, we know that a diet that's rich in red meat or processed meat increases the risk potentially of colon cancer, versus a diet that's rich in fruits, vegetables, whole grains, and high fiber decreases the risk of colon cancer. We also know that exercise can be really helpful. Reduction of things like smoking and otherwise can also be helpful too. There's more and more studies coming out around the microbiome, which I think is really interesting, and an interesting thing that we can loop back on when we learn more. But that also has been found to influence, which is really related to our dietary intake as well.
Yeah. And I think, talking about those risk factors that are modifiable is important, because that gives people something that they can actually do to modify the risk or change their risk. You can't change your family history, right? That's something that you're born with. But even things like you mentioned, regular physical activity have been linked to lower risks of colon cancer. So something as simple as a daily walk. There have been studies literally that have been done on people taking daily walks between 20 and 30 minutes, and that actually having a significant impact on your risk of colon cancer. Of course, like you said, avoiding smoking, limiting alcohol are important, because those have not only been associated with the risk of increased colon cancer, but cancers all around. Smoking and alcohol is definitely an important modifiable risk factor. And then, of course, we can't forget about weight management. Obesity certainly has been linked to a higher risk of cancer, especially for colon cancer. And so trying to maintain a healthy weight is an important preventative measure as well.
Totally. And the last preventative measure that we've talked a lot about today, and we don't mean to sound like a broken record, but we can't overemphasize the importance of screening, because again, our uptake in our practices across Canada is quite low for colon cancer screening. But again, this is something that we can change. We're hoping to change that with this episode, that we share this information so that you get your screening done, because it is a preventative way of taking action for your health. And regular screening can help catch those abnormal growths early before they develop into cancer. So that, alongside the lifestyle changes that we just mentioned, are the best way that we can reduce our risk.
Absolutely. And early detection through screening can prevent more severe outcomes, which is what I see in the emergency department, right? And so I don't want to see people who are already like having that severe weight loss, having that severe abdominal pain, having a change in their stools or blood in their stool, because at that point, like the cancer is typically advanced, and then that's going to change the outcomes. And so that really does bring us to our prescription for today. If you're listening and you've been putting off that FIT test or that colonoscopy, please take this as a sign to use this as self-care, and please just talk to your family doctor and go ahead and book it.
So thanks everyone for tuning in today to the Doc Talk podcast. But it's just a quick reminder that the Doc Talk is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. So always speak to your own healthcare provider for questions related to your own personal health needs. And please be sure to follow us on our social media at the Doc Talk. And please send us your questions so we can do a deep dive into any concerns that you may have around your health.